I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. We're going to continue with another perinatal infection. Today we'll be discussing the T in torch infections. I hope you're not sick of it yet. Sorry. Mel, can you kick us off with what is toxoplasmosis?
Okay, so toxoplasmosis is the only one of our perinatal infections that is a parasite. To be specific, Toxoplasma gondii is an intracellular parasite. Now, see if you can think back to university or school to what a parasite is.
I remember lots of life cycles.
Exactly. A parasite lives in or on another species, otherwise named host, and gains its nutrients from that host. Unfortunately, it usually comes at the expense of the host.
Just like a leech.
Yes, exactly like a leech. Now, toxoplasmosis itself has two life stages. First is the feline stage. The cat is its definitive host. After reproducing within a cat, unsporulated oocysts are excreted in the cat's feces. Unsporulated just means that it's in the early life cycle and not yet infective. Essentially, as they contact oxygen and moisture, they change and become sporulated. Apologies to all parasitologists out there. This is just a very simple summary for our listeners. We then enter the second non-feline stage. Tissue cysts containing bradyzoites or sporulated oocysts are then ingested by an intermediate host. This is usually due to contaminated food or water. This is one way that humans can be infected, directly through food or water infected with cat feces. Other intermediate hosts include any other warm-blooded animals like sheep or cows. Once ingested, the gastric acid digests the cysts and releases the bradyzoites. These are then transformed into tachyzoites, which can infect all cells of the host. The host's immune system will either clear these tachyzoites or force them into tissue cysts. These cysts are most commonly found in the muscle, the brain, and the heart. Any predator of these intermediate hosts who consumes these cysts will then become infected. This is the other way that humans become infected, by eating undercooked or raw meat of an intermediate host.
Okay, it's pretty gross to think that you may have a cyst of a parasite just living in your muscles. But to summarize the routes of transmission, they are: first, through direct contact of contaminated litter, water, or soil containing oocysts from cat feces. And secondly, through consuming undercooked or raw meat containing tissue cysts. And thirdly, vertical transmission.
All right, so before we get to vertical transmission, it's my turn for an interesting fact. Slight tangent here. Now, we've all heard of crazy cat ladies, right?
Yes.
So crazy cat lady syndrome is a terminology that was used by media agencies to link toxoplasmosis infection to neurological, mental, and behavioral disorders. There's a varying level of evidence to support this link. Certainly those with immunodeficiency, like HIV, can develop severe neurological symptoms relating to toxoplasmosis and encephalitis.
Wow, there you go. That is a good one. Note to self, don't buy lots of cats. Now, I've never actually seen a case of congenital toxoplasmosis. So how common is it?
It's very rare in Australia. If you look at any of the Australian guidelines on toxoplasmosis in pregnancy, it just says it's rare. I did a quick literature review, and the last article on the epidemiology of congenital toxoplasmosis in Australia that I could find was published in 1991. At that time, in Western Australia, the birth prevalence was 0.23 per 1,000 births to non-immune mothers. The article didn't comment on clinical sequelae for the infants. Another review article that looked at the torch screen as a whole had no cases of congenital toxoplasmosis, and I'll chat about that article a bit later. In the USA, the incidence of congenital toxoplasmosis is 0.8 per 10,000 live births. In the UK, it's 1 to 2 per 10,000 live births, and in France, it's 10 per 10,000 live births. You'll note that the incidence is much higher in France, and if you've been to France and eaten their French food, you'll probably know why. Last time I was there, I certainly had some beef tartare, and it was delicious.
You sure it wasn't all those cats you were hoarding at the time? So vertical transmission is highest if the mother is infected immediately before conception or very early in the pregnancy. Overall, the transmission rate is about 40 to 50%. In those with a long-standing infection, however, vertical transmission is rare. Someone is susceptible to a primary infection if they have never had toxoplasmosis before. For example, both of their IgG and their IgM are negative. The rate of vertical transmission and the clinical effects do vary by the trimester of the primary infection.
If the primary infection occurs during the first trimester or immediately prior to conception, then the fetus is likely to have more severe clinical disease. The transmission rate is approximately 4 to 15%, but of those that become infected, up to 85% are associated with fetal loss or severe disease.
If the primary infection occurs during the second trimester, then the transmission rate is higher, up to 45%, but the clinical effects tend to be non-fatal and less severe. In this case, up to 1/3 have clinical features.
And if the primary infection occurs in the third trimester, then the rates of transmission are high, at about over 60%. In this case, however, there is a low rate of clinical sequelae for the fetus, between 4 to 17%, and this tends to be mild or even asymptomatic.
Okay, so when might we suspect someone has a primary infection?
This is an infection that most people would be unfamiliar with, so let's go through it. In those with an intact immune system, the majority of infections are subclinical. Only 5 to 10% experience symptoms that are vague and nonspecific. These include flu-like symptoms, fever, malaise, lymphadenopathy, and headache. Those who are immunocompromised experience severe symptoms, which may include encephalitis, retinochoroiditis, or mass lesions.
Gee, that's pretty serious. What are the features of congenital toxoplasmosis?
Well, we can divide these into fetal toxo and neonatal toxo. There are a few overlapping features. The important fetal features are those which can be identified on ultrasound. Fetal toxoplasmosis is associated with miscarriage, stillbirth, and prematurity. Ultrasound features we might expect to find include fetal growth restriction, hydrocephaly, ventriculomegaly, intracranial or hepatic calcifications, ascites, hyperechoic bowel, and placental thickening. Now, with neonatal toxoplasmosis, only about 10 to 15% of these will actually show signs at birth, but they're still at a high risk of developing symptoms months or even years later. The features of neonatal toxoplasmosis include hydrocephalus, intracranial calcifications, microcephaly, chorioretinitis or blindness, deafness, strabismus, epilepsy, psychomotor or mental retardation, petechiae, anemia, and jaundice.
And I've heard of a triad associated with congenital toxoplasmosis. What's that?
The triad includes chorioretinitis, cerebral calcifications, and hydrocephalus, and this is often associated with seizures. So, let's do a quick summary so far.
Excellent idea. So Toxoplasmosis gondii is an intracellular parasite. It's transmitted to humans through 3 routes. First, through direct contact of contaminated litter, water, or soil containing oocysts from cat feces. Secondly, through consuming undercooked or raw meat containing tissue cysts. And thirdly, vertical transmission. The rate of congenital toxoplasmosis is rare. The rate of vertical transmission and features of congenital toxoplasmosis vary by trimester. If the primary infection occurs during the first trimester, then there's a lower rate of transmission, but the fetus is likely to have more severe clinical disease or even fetal loss. If the primary infection occurs during the second trimester, then the transmission rate is higher, so up to 45%, but the clinical effects tend to be non-fatal and less severe. And if the primary infection occurs during the third trimester, then the rates of transmission are high, but the fetus is likely to be asymptomatic with no long-term problems.
Clinical features of a primary infection include being asymptomatic, flu-like symptoms, fever, malaise, and lymphadenopathy.
And features of congenital toxoplasmosis include miscarriage, stillbirth, and prematurity. And the ultrasound features such as fetal growth restriction, hydrocephaly, ventriculomegaly, intracranial or hepatic calcifications, ascites, hyperechoic bowel, and placental thickening. Then for neonatal toxoplasmosis, features include hydrocephalus, intracranial calcifications, microcephaly, chorioretinitis, deafness, strabismus, epilepsy, psychomotor or mental retardation, and petechiae, anemia, and jaundice. Alrighty, so now we know what the clinical effects of toxoplasmosis are, but who do we test? I haven't seen it as a part of routine antenatal screening.
In Australia, screening is not recommended for toxoplasmosis. There are pros and cons as to why this is the case. On one hand, the majority of the population is seronegative, and thus if a primary infection is suspected, treatment can be started to prevent vertical transmission. But on the other hand, because it's so rare in Australia, you'd be doing thousands of unnecessary tests, and even if someone tested positive, it's possible to be a false positive. In some European centres, however, with a higher background incidence, screening at booking and throughout the pregnancy is sometimes routine.
Right, so we don't screen everyone. Who do we test then?
Well, there aren't any strict guidelines for who to arrange testing for, but toxoplasmosis serology is commonly arranged as part of the TORCH screen. Situations where this is arranged include ultrasound findings suggestive of a perinatal infection, including multiple fetal anomalies, particularly ventriculomegaly, hydrocephalus or calcifications, fetal growth restriction, or polyhydramnios, and symptoms suggestive of acute toxoplasmosis like fever, malaise, lymphadenopathy, and flu-like symptoms.
The mainstay of serologic testing involves IgG and IgM. However, IgM can stay positive for months to years, making interpretation tricky.
In someone who tests positive for both IgG and IgM, or even negative for IgG but positive for IgM, additional testing and considerations come into play. The next step is to check symptoms, recheck the IgG and IgM, and check the IgG avidity. A repeated high IgM level or a low IgG avidity suggests a recent infection within the last 3 months. A low IgM or a high IgG avidity, less than 16 weeks gestation, suggests a past infection and no further action is required.
But a high IgG avidity after 16 weeks doesn't completely rule out early pregnancy infection. That's an important caveat.
Agreed. If there's suspicion of recent infection, further testing is needed.
All right, can we continue our discussion about the interpretation of the toxoserology?
So if a patient is IgG and IgM negative, there's no past infection. We provide education on prevention and repeat testing if symptoms develop. These patients are susceptible to a primary infection.
If IgG is positive but IgM is negative, this indicates a past infection, so no further action is needed. We use serology to determine if the pregnant person has a primary infection or not. That brings us to fetal diagnosis. Carla, what are the key approaches?
We have a few options. Ultrasound and MRI can suggest fetal involvement, but their sensitivity and specificity are limited. Generally, a referral to maternal fetal medicine to consider an amniocentesis with T-Gondii PCR is recommended. This should be done at 18 to 20 weeks or at least 4 weeks after maternal infection. This has high sensitivity and specificity for confirming fetal infection. And if the PCR comes back positive, what's our management?
Whoa. Let's back it up a little bit. So we actually consider treatment of the mother at the time of maternal diagnosis of a primary infection. Remember that we only do the amniocentesis weeks after the maternal diagnosis to see if the fetus is affected. Spiromycin is the first-line treatment in this situation. It's a macrolide, considered safe in pregnancy and concentrates within the placenta. Note, it does not cross the placenta. So it's useful in this situation with a confirmed maternal infection to try and prevent a fetal infection. Spiromycin reduces the rate of vertical transmission by 60%. If, as you say, Carla, the PCR comes back positive, then our options include termination of pregnancy after counselling or treatment from at least 18 weeks onwards. A positive PCR for toxoplasmosis on amniocentesis is considered a confirmed fetal infection. Treatment from 18 weeks onwards includes changing from spiromycin to pyrimethamine and sulfadiazine. This should be continued until delivery. Pyrimethamine is contraindicated in trimester 1.
What's the importance of pyrimethamine and sulfadiazine?
These medications help to reduce the severity of congenital toxoplasmosis. They don't reverse any damage that's already occurred, but still it does lower the risk of serious neurological sequelae and fetal death. In those with a confirmed fetal infection, the newborn's diagnosis should also be confirmed postpartum, and in neonates with symptomatic congenital toxoplasmosis, the treatment continues for 12 months. alternating between the pyrimethamine sulfadiazine and spiromycin.
And what if the amnio-PCR is negative?
In this case, we continue spiromycin alone, or after 18 weeks, we can still escalate to pyrimethamine and sulfadiazine.
Other management considerations include a referral to maternal fetal medicine and involvement of an obstetrician. If there is a confirmed fetal infection and the patient is choosing to continue the pregnancy, to consider an antenatal referral to a pediatric infectious diseases specialist and neonatology. Counselling the patient and the family regarding the likely outcome of a positive toxoplasmosis serology, ensuring the patient has access to accurate information, and providing a clear management plan in the chart.
Obviously, we need to learn all about diagnosis and treatment for exams, but as for all perinatal infections, prevention is key. That means avoiding raw or undercooked meat, washing hands after gardening, thoroughly washing vegetables, and minimizing contact with young kittens and their litter. That's right, if you own a cat, you can absolutely make your partner change the kitty litter.
So these measures are very simple and effective. Now, before we move on to a final summary, I wanted to do a mini evidence with Anne. Don't worry, it'll only take a few minutes. So the article that I wanted to discuss was published in 2021 in the journal Prenatal Diagnosis by Fitzpatrick et al. And from what I can see, Fitzpatrick was a medical student at the time of publication and working with the MFM specialist team at the Mercy Hospital for Women in Melbourne, Victoria. The article is titled A Systematic Review of Maternal Torch Serology as a Screen for Suspected Fetal Infection. The reason I was doing this bit of a dive into PubMed was that I was pretty unconvinced of the usefulness of arranging a torch serology for so many people, especially as discussing today. Toxoplasmosis in particular is pretty rare. So the paper included 8 studies, a total of 2,538 pregnancies. The common indications for torch serology included polyhydramnios, fetal growth restriction, hypoechogenic bowel, and other ultrasound abnormalities. There were only 31 cases of confirmed congenital infections of the over 2,500 pregnant women who had a torch screen done. Overall, these included 5 cases of confirmed parvovirus and 26 confirmed cases of congenital CMV. 15 of the cases of congenital CMV had multiple ultrasound abnormalities. And importantly, in relation to this podcast episode, there were no cases of toxoplasmosis and also no cases of rubella or HSV. When they specifically looked at the toxoplasmosis, out of the 2,500 tests that were done, there were 2 positive maternal serology results, but there were still no cases of congenital infection. I guess when the researchers looked at the indications for arranging a torch serology, those who had just isolated polyhydramnios, there were no cases of congenital infection. In those who got a torch screen done because of fetal growth restriction, there were 10 cases, or 2%, which had a confirmed fetal infection. And out of those 10 cases, 8 had multiple fetal anomalies. And in the 2 cases of isolated fetal growth restriction, they both had congenital CMV. When they looked at isolated abnormalities, the only ones that were associated with congenital infection included fetal growth restriction, echogenic bowel, and ventricular megaly. I guess really the paper was just highlighting the kind of overall unnecessary use of torch leading to false positives, invasive procedures, a huge cost to the health system, and parental anxiety. Obviously important to learn about the torch screen and infections for both work and exams, but it's important to really consider the clinical evidence of arranging a torch screen. And I think I'll probably discuss this a bit further in future episodes.
Yeah, definitely. Such an interesting point. I think that's really going to make us consider more carefully about who to actually arrange a torch screen for and who to just do a CMV for. So this has been a really good discussion. And toxoplasmosis in pregnancy is complex, but understanding its diagnosis, management, and prevention can significantly impact outcomes. So time for one last summary. Toxoplasmosis gondii is an intracellular parasite. It is transmitted to humans through 3 routes. First, through direct contact of contaminated kitty litter, water, or soil containing oocysts from cat feces. Secondly, through consuming undercooked or raw meat containing tissue cysts. And thirdly, through vertical transmission. The rate of congenital toxoplasmosis is rare, with the rate of infection and features of congenital toxoplasmosis varying by trimester. In the first trimester with primary infection, there's a lower rate of transmission, but the fetus is more likely to have severe clinical disease or fetal loss. In the second trimester, the transmission rate is up to 45%, but the clinical effects tend to be non-fatal and less severe. And with primary infection in the third trimester, then the rates of transmission are high, but the fetus is likely to be asymptomatic with no long-term problems.
Clinical features of a primary infection include being asymptomatic, flu-like symptoms, fever, malaise, and lymphadenopathy.
And features of congenital toxoplasmosis include miscarriage, stillbirth, and prematurity. Ultrasound features such as fetal growth restriction, hydrocephaly, ventriculomegaly, intracranial or hepatic calcifications, ascites, hyperechogenic bowel, and placental thickening. And features of neonatal toxoplasmosis include hydrocephalus, intracranial calcifications, microcephaly, chorioretinitis and blindness, deafness, strabismus, epilepsy, psychomotor or mental retardation, petechiae, anemia, and jaundice.
Routine screening for toxoplasmosis is not recommended in Australia. You would consider arranging serology for toxoplasmosis in the setting of ultrasound abnormalities, as mentioned above, particularly ventriculomegaly and calcifications, or if there's symptoms of a primary infection in the mother. Serological testing involves toxoplasmosis, IgG, and IgM. If someone who tests positive for both IgG and IgM, or negative for IgG and positive for IgM, we need to check symptoms, recheck the serology, and check the IgG avidity. A repeated high IgM level or low IgG avidity suggests a recent infection. A low IgM or high IgG avidity before 16 weeks suggests a past infection and no further action is required.
If a patient is IgG and IgM negative, there's no past or current infection, but the patient is susceptible. And if the IgG is positive but the IgM is negative, it indicates a past infection, so no further action is needed.
Fetal infection is confirmed by amniocentesis with a positive toxoplasmosis gondii PCR at least 4 weeks after the primary infection, and it tends to be done between 18 to 20 weeks. For management, after a confirmed maternal primary infection, sparomycin is the first-line treatment and reduces the rate of vertical transmission by 60%. If the amnio-PCR is positive, then options include termination of pregnancy or treatment from at least 18 weeks onwards. Treatment from 18 weeks onwards include changing from sparomycin to pyrimethamine and sulfadiazine. This should be continued until delivery. Pyrimethamine is contraindicated in the first trimester. Pyrimethamine and sulfadiazine lowers the risk of serious neurological sequelae and fetal death. And if the amnio-PCR is negative, we continue sparomycin alone, or after 18 weeks, we can still escalate to pyrimethamine and sulfadiazine.
Other management considerations include a referral to MFM and involvement of an obstetrician. If there is a confirmed fetal infection and the patient is choosing to continue the pregnancy, consider an antenatal referral to the pediatric infectious disease specialist and neonatology. Counsel the patient and family regarding the likely outcome of a positive toxoplasmosis serology. Ensure the patient has access to accurate information and provide a clear management plan in the chart. In those with a fetal infection, the newborn's diagnosis should also be confirmed postpartum. In neonates with symptomatic congenital toxoplasmosis, the treatment continues for 12 months.
And that's it. Thanks for tuning in to the Uterine Sound. Summary slides will be coming your way in the next week on our Instagram. You can check us out on socials at the Uterine Sound, and we love hearing from you. So feel free to get in touch by email at theuterinesound@gmail.com or on our website, www.theuterinesound.com. Tune in next time as we continue our discussion on perinatal infections.